reports from the team conference, seeing what their goals are, whether they're reasonable, and whether they're progressing towards those goals. And as I said before, they require that close supervision of the physician, not only for their medical needs, but a physician that's also qualified to go ahead and develop the most appropriate physical therapy, occupational therapy, speech therapy to show the improvements that these patients will need. So if they need skilled therapy, but they're not that quite complex or intense, they may still need some daily skilled services. So the criteria that we're looking for medical necessity of daily skilled therapy is that they have that nursing or rehabilitative need. They require those on a daily basis in order to progress and improve and overcome their functional deficits. That these services really can't be provided as outpatient, that they're best served by getting those services on an inpatient basis and typically a nursing home. And again, that they're reasonable and necessary for the patient's illness, and they're going to establish some type of safe and effective maintenance program and prevent their further deterioration. Now, the big issue that always comes up are the custodial or the skilled. And custodial care, as we talked about before, were primarily those type of services that assist you in your activities of daily living. And some of these things are going to be quite obvious, but I'm going to go through a few examples of custodial care. And again, the dressing, the eating, the toileting, typical activities of daily living. Some of the skin care and other topical treatments may at some point be skilled, depending on the intensity of therapy, but a lot of times as they progress they can get to a level where they can be provided by non-skilled people that have been taught the appropriate interventions. There was a concept that tube feedings would automatically qualify if you're 100 days in a skilled nursing facility. If those people are on tube feeding, they're going to require that for the rest of their lives. Once they get to a certain point where those interventions can be taught to a non-skilled person, that would not necessarily qualify them for 100 days of skilled care. It would allow them to transition to a custodial level of care, because this is the type of care they are going to require for the rest of their lives. Now, if they're continually adjusting their tube feedings, they're trying to taper them off the tube feeding, they're trying to get them on oral nutrition, that would still be a skilled level of care, because you have to observe their response to the changes that you're making with their volume of tube feedings or whatever changes you're making in their delivery of the tube feeding in order to assess whether it's improving. But once it gets to that stable setting where they're on the same regimen day in and day out, that's then transitioning over to the custodial level of care, and we're going to see those people being denied their inpatient skilled care and have to look at other alternatives to go ahead and provide that necessary service, but through a non-skilled provider. Typical incontinence care, the use of catheters. Again, sometimes these things can be skilled in the initial setting, but they'll transition into a setting where they can be provided